Good afternoon, everyone. Thank you very much for joining us in this second of our Efemia Academy webinar series. Today, we're very delighted to introduce Clare Bourne, who is a pelvic health physio who runs a very successful private practice in central London and is a passionate speaker on pelvic health and breaking down the barriers to accessing the help that so many men and women need. Her excellent talk today will cover how to optimize recovery in the postnatal period, including the pelvic floor muscles, of course. She will explore why these muscles can struggle, how we can support them recover, and how to treat and navigate symptoms that may occur. So the talk will last about 20 minutes. We will have a brief Q&A session afterwards. You'll be able to type your questions in the Q&A box, and Claire will very happily answer those. This session will be recorded. So if you need to dash off to work, don't worry. It will be posted to our website on exactly the same page where you registered for the webinar. So without further ado, we will hand over hosting to Claire and enjoy the show.
So yeah, thank you for the lovely introduction, and that's a perfect summary of me. So yeah, I'm a pelvic health physiotherapist, and I'm based in London, and I'm really passionate about supporting women through that fourth trimester, and really a lifelong thing. And I like to think about the perinatal period within a lifelong journey for a woman, because I think there can be a big focus on the perinatal period, and sometimes we forget about what's happened around that. But I am passionate that we get this time of women's life really done really well, and having gone through it twice myself as a mum of two, I know how important good support and good care is in this time, and I found it hard even though I knew everything and had all the information. So I think how we can all optimize that support and care is absolutely vital. So what I want to cover today in our 20 minutes plus that we've got together is ultimately, yes, we need to think about the fourth trimester, and that fourth trimester is, I think, probably quite a new concept around, but that idea that from birth for the first 12 weeks of a baby's life and a mother's recovery is the fourth trimester. And I think it's time when actually women are going through one of the biggest transitions of their lives into motherhood, the physical changes, navigating a body that potentially doesn't feel like their own. And I think pregnancy can feel like a more gentle transition than the postpartum period, because it's very gradual over time. So yes, I think what's really important is that we understand how pregnancy is more gradual, but postpartum is quite a big physical shock. And I think generally in the UK, where I'm based, we're not necessarily amazing at preparing women for postpartum physical recovery of themselves. A lot of our antenatal education is very much focused on how you're going to birth your baby, how you're going to care for your baby in these early days, but not necessarily the reflection on how a woman can look after herself. And so I think it's really important that we understand what is going on in that time, especially from a pelvic floor and pelvic health perspective, and kind of the bite-sized things that we can support individuals with without overwhelming them, to help them navigate that time. Because I think what's really important for us to always to consider is that pelvic health symptoms have a huge influence on mental health, can be vice versa as well. And that can have a huge impact on a woman's initial weeks, even bonding with their baby. So it's a really important topic that we consider. So we're going to think a little bit about pregnancy, and obviously as a woman's going into the fourth trimester, how we can nurture, don't know why I've got balloons, how we can nurture the pelvic health in that time, and how to navigate symptoms. So let's go from there. So I think first of all, we need to be really clear of what we are saying by the pelvic floor, because I think a lot of the time we just think we're talking about musculature. And yes, the pelvic floor muscles are part of the pelvic floor, but if we're familiar, and obviously this image here shows the pelvis, but I've also got that pelvis here. Yes, the pelvic floor is the muscles, but there's also the connective tissue, fascia, sphincters, which are little rings of muscle around the urethra and around the anus. And it's important that we remember, as part of this conversation, that we're thinking about all of this and not just, are you doing Kegels or not doing Kegels? We have to think about the pelvic floor, and in my opinion, pelvic health as a wider topic, and the acknowledgement that there is a lot more going on in the pelvis than just the pelvic floor muscles postpartum. That has to be at the forefront of our minds. But I think connecting with women on this topic is they often think about their pelvic floor muscles, but supporting with the understanding of the vaginal walls and the fascia around there and the impact on that as well is also really important, and a huge part of actually the work I find I do in clinic postpartum, to help them understand how their body has changed, not necessarily forever, but some of the changes that it's gone through and is going through at that present time, which I think can be a real shock to the system for a lot of women. So that's why I want to just make sure that we're all clear on what are we talking about when we actually say about the pelvic floor. And as I say, I'm really passionate to think about the wider pelvic health team. And I often talk about, the importance of the pelvic health squad, all of them together. So women, that is the muscles, the bladder, the bowels, the bony structures of the pelvis as well as the uterus and the vagina. And we have to keep that all in mind when we're supporting individuals, because this part of our body, everything is close together. So I think anatomically in diagrams, it makes it look like your bladder's here, your womb's somewhere here, and your bowel's over here. But really, they're right next to each other. And actually, as you look down into a pelvis, medics will be familiar with this. Everything is sitting right next to each other and on top. And we talk about them like neighbours. You can hear your neighbours through the wall if your houses are attached. And what's going on with one of them will impact what's going on with the others. And that cannot even be more true in the 4th trimester. So let's just briefly think about how does pregnancy. I think we're familiar with the fact that, yes, okay, the baby sits down in the pelvis on the pelvic floor, and this puts pressure and impact onto the muscles. But what else is going on? A big thing that women experience in pregnancy generally is constipation. And so many women are embarrassed to talk. I think generally women get better at talking about their bowels postpartum, almost don't always have a choice not to. We have kids that were then talking about their bowel movements more as well. But it can feel quite shame-filled and quite embarrassing to talk about bowel movements. But constipation that is ongoing for months and months, which results in a lot of straining down into the pelvic floor, not only affects just the muscles themselves, but again, that connective tissue as well. So really trying to think about our education as a wider piece and how we can support pelvic floor health through pregnancy to aid the 4th trimester. And I think ultimately, if we look at research, the research says that doing regular pelvic floor exercises in pregnancy really prevents our incontinence potentially postpartum and in that 4th trimester. Now, it's never too late, but I think it's really important that we always view an individual as a whole. And some of the bladder habits that we might get into as well, and how that can then drive other habits postpartum. Often you need a wee more frequently. That's unsurprising when a baby's sitting there. You might be getting up at night. And some of those habits then can stay with us into the 4th trimester. So I just wanted to briefly touch on that so we don't forget where we've come from as we enter into the 4th trimester. And then obviously the transition into the 4th trimester is through birth. And really it's the birth that we really need to think about as the impact of what's going to happen. So depending on how a woman births her baby will obviously have different impacts on the pelvic floor. So we're thinking up here with our image here, it might look like this. Birth might look like this, but it may not, and for many, many women, it doesn't. But a vaginal birth has an impact on the pelvic floor. And I'll talk a little bit more about the specifics of that in a moment. Cesarean birth, does that mean that we don't think about the pelvic floor anymore? Maybe, maybe not. I think there's a lot of myths around that. And then instrumental deliveries, this example here with this image is a forceps. And now we know when the majority of cases when a forceps delivery is done, we need to do an episiotomy, which is a cut to the side, which includes the pelvic floor. So depending on how we birth, there will be some impact on the pelvic floor and the tissues around that. And again, that's why we need to keep that mindset of what's going on around the pelvic floor, because that is equally as important as what's going on in the pelvic floor, because they don't work like other muscles in isolation. So let's break this down a little bit more. So in a vaginal birth, okay, the baby is moving through the pelvic floor. Now, some of the research shows that some bits of the pelvic floor stretch 2.5 times their length, which is phenomenal. And if you think about where a baby's passing through, it's this part of our pelvic floor. Makes sense that those muscles need to really stretch to allow that baby to be birthed, which is phenomenal and an amazing ability that our muscles can do that to allow babies to be born. But that's obviously a significant stretch on a muscular tissue. And I think what's really important is also always to understand and remember this is skeletal muscle, like a bicep, a tricep. Yes, the presentation is different, and yes, they have different shapes and sizes. And the pelvic floor is actually made up of lots of little muscles. When we say the pelvic floor muscles, they've actually got individual names, but they work together. And I think understanding that that's been through a huge stretch, if you mentally thought about any other muscle going through such a stretch, you would understand why it needs such a big rehabilitation program. If a hamstring or a bicep went through, you'd probably understand that your leg and your arm is not going to quite function in the same way. And I think that helps individuals as they navigate and understand their body in these changes to think, wow, yeah, okay, that's amazing, it's done that. But yeah, fair enough, that's why I really have to kind of tap into this rehab and recovery that needs to be done. And we're still not great at educating people about that, I find. But as I say, we can't be one-dimensional about muscles here. We have to understand that obviously the vaginal walls also hugely stretch during a vaginal birth. Again, designed for it. They've got wrinkles called rugae, and they're designed to stretch and move to allow our babies to be born. I describe it a bit like an accordion. If you imagine like an accordion opening and then closing, the rugae allow for that, but they've also been through a huge stretch, and that takes time and recovery. Nerves can also get impacted, especially if, say, a baby takes a little bit longer to come down the birth canal. Generally speaking, kind of 2 hours is more the maximum they allow for that. But if you think about those tissues being on stretch for 2 hours, as well as the nerves around that area and the nerves that innervate our pelvic floor and our sphincters around the urethra and the anus, that's going to have a huge impact on them. That's a lot of pressure and stretch. So we need to think about that in the whole picture. Some people have these very transient bladder symptoms as they move into the 4th trimester because of some of the impact on the nerves. Perineal tears. So I've sort of discussed this a little bit by talking about like an episiotomy during a forceps delivery, but there are 4 classifications of perineal tears: 1st, 2nd, 3rd, and 4th. And they get more severe as we go up to the 3rd and 4th trimesters. So sorry, into the 3rd and 4th degrees, not the trimesters, into those degrees. And I think what's really important is, again, for individuals to understand. So many women end up in my clinic and they have no idea what any of this means, and they don't understand that there's been some tearing to a muscle. When people understand what's happened, and I think we don't want to scare women, but not being educated really impacts your compliance with doing anything. Where someone tells me, you know, there's been an injury to your muscle, my understanding is, great, I need to rehab and recover that muscle. It doesn't mean I can't, it just needs some input. And we know that instrumental births obviously put more impact to some extent on the vaginal tissues. And again, having some understanding of that in your recovery is important as you navigate that time. So, cesarean birth. Okay, there's less impact. Okay, I think we can probably understand that there's not that significant stretch on the pelvic floor, but they've still gone through pregnancy. And there is so much myth that I get, and women say, well, I don't need a pelvic floor checkup. My pelvic floor's fine. The baby didn't come through there. That's fine. But again, it's too one-dimensional. It's not thinking about what's been before. And maybe the other parts of the story, you know, lots of women post-cesarean struggle with constipation. It can take a little while for the gut to get back in. So as they navigate that 4th trimester, lots of them struggle with their bowel. Now that has an impact on the pelvic floor as well. And so we must think about that as a wider picture and make sure we're not just speaking to one part of the population in just thinking this is about vaginal births or instrumental deliveries. It's for everybody. So is pelvic floor recovery needed? I think it looks different, and I think that's okay for us to own that and discuss that. And I don't think we should shy away from that. But it doesn't mean that we shouldn't do it, and we shouldn't be encouraging that, because it's really, really, really important. And what I sometimes find with women who've gone through a cesarean birth with their first is they've navigated really well through the 4th trimester, they've returned to exercise and they've done everything. Then they have another pregnancy or another subsequent pregnancy. And it's then, because they've not really kind of approached, I guess, their pelvic floor health or navigated that time, they've kind of neglected it and they've thought, well, it's not relevant to me. In all honesty, it's relevant to all of us, whatever our gender, whatever our age. Pelvic health is important. And yes, there are certain things in life that might make it more important for us to consider and less important for us to consider, but this population still needs this support and education. And I think we're not necessarily very good at doing that. So I think what's really important is what symptoms might individuals kind of navigate or have in this time. As you can see, the list is quite broad, and this is me just kind of touching the surface. But individuals, a lot of women will have bladder symptoms. And I think when you break down, for me, mentally, the 4th trimester, I think about it as the first 6 to 8 weeks and then the kind of next 6 weeks onwards. And really the 4th trimester is that 12 weeks. But I think for a lot of us, it's a little bit more transient and a little bit more mobile as to, I think I expected at 6 weeks just to be like, right, 6 weeks postpartum, I'm feeling ready, bring on the world. And if I'm honest, I didn't feel like that. By 12 weeks, yeah, I felt a little bit different and I felt physically more like me. But I think, again, having those conversations to be like, the research shows that parts of your recovery is still going on for a year postpartum. So don't worry if you're still not feeling 100% like you or symptoms haven't completely resolved. What individuals need is realistic timescales and a plan. And that is mentally what really, really helps. So I think understanding in those early days and weeks, especially after a vaginal birth, that incontinence can absolutely occur. Okay. And that doesn't mean that this is you now for life. I know a lot of women panic thinking, oh gosh, this is me now. No, again, the stretch, the impact on the nerves, these can cause these transient symptoms. So again, understanding that this might be short term, but let's think about how we can improve that is really important. Some women may feel like they have to get to the toilet a lot quicker. That's really, really common. And they might have decreased confidence. What I generally say is if you're having these in the early weeks, just kind of like manage life around it. But if this is something that is ongoing 6-8 weeks, again, through the 4th trimester beyond, it's impacting your quality of life. It's decreasing your confidence. You can't go out because your bladder is dictating your life. This is something we absolutely should not be normalizing, even though it still sadly is at times that incontinence is just part of motherhood. We actually should be referring on, and we should be seeking professional support to help with that. Again, we shouldn't also think that we have to limit the exercise that women get back to because of incontinence. We should be making sure we've got everything in place to support them to make sure that happens. Bowels. So obviously I've talked a bit about constipation. That's really important that we treat, but also women may be the other end and actually feel they've lost control of their bowels to some degree. That may not mean they're having incontinence, but it might mean they're rushing to the bathroom a lot. It's much more urgent. And that window of opportunity is challenging because if you're, say, feeding your baby and you suddenly get the urge to go, well, what do? You know, it's really, really difficult. And so women need support in how to navigate that, because that's very distressing and can feel really, really isolating, especially if at home on your own with a baby. Prolapse. So this is a huge topic and I could talk about an hour about prolapse, but I think understanding and again, educating that prolapse type symptoms of this heaviness, this dragging, this pressure, really, really common and expected in the early days. This as a persisting symptom, something that's going on through the 4th trimester and beyond, not something that we want to tolerate or allow, and something that we do want to support you with. And I think talking about sexual function is really, really important. I mean, to honestly, the first bit of the 4th trimester, it's not on anyone's minds, but most of the time. However, for women, as they move past that 6 to 8 week point, which can feel like a very pivotal moment, and I think there's a lot of pressure on, you know, this 6-week check that women are often expecting or may not get, feeling as a clearance for exercise, for intercourse, but they may not get the information and advice they need. But I think understanding what is going on in the body, I think vital information women need to understand is the changes to the vaginal and vulval tissues during this time, especially if you're breastfeeding. The prolactin is up, the estrogen is suppressed. And when we have low estrogen, as we understand during perimenopause, menopause, it makes the vaginal and vulval tissues drier. So you go from this pregnant time when you've got loads of estrogen into this 4th trimester when you've got significantly less, and the tissues that has an impact on the tissues and returning to intercourse. So I think just these basic snippets of education, honestly, when you say them to women, they're like, oh, that makes so much sense. Especially that kind of cesarean group who are like, well, I didn't birth a baby through my vagina. Why is it uncomfortable? Why is it painful? They need to understand the tissue changes. And we are just not educated about this. This is just not normal information that we receive. And so any of us working with this population, it's so important that we can give them these small bits of information to help them so they don't feel alone. And I think women are getting better at talking about these things, but they're not necessarily better at talking to medical professionals about these things. They're better at talking to their friends about it. So I always say if one woman knows, she can support her friendship group, and that's how we make change. So how can we nurture and optimize recovery during this time? Okay, and I'm keeping an eye on the time, but I think what's so important is education. And I've talked about that already, about how important that is. Education, education, education. It doesn't have to be complex. It can be simple. Bowel TLC, and I'm going to talk about that a little bit more. Really properly understanding how to do pelvic floor exercises. When can they start? What should they be doing? And encouraging movement and activity, but that is appropriate and safe for the 4th trimester. So bowels, like how do we take care of our bowels? Okay. Now, again, I don't think we're talked about the basic education and understanding of what it means to look after our bowels, you know, fluid being vital, especially in the 4th trimester as we navigate feeding. And everyone may not breastfeed. That's totally fine. But however we're feeding, we need to understand that the fluid that we get into our body is vital for our bowels and for our stools. So fluid and fiber, 30 grams of fiber is what we're advised, and most of the population is not getting that. Now, I think when you say 30 grams of fiber, someone's like, I've got no idea what that means. So I think I try to talk to them practically, thinking about plants in every meal, thinking about flaxseed or psyllium husk that we can add in. You know, what can we add into your diet to support that? Eat the biscuits. You know, I ate so many biscuits in the 4th trimester. I was tired. I was navigating a new season of my life. That's fine. But how can we add in stuff rather than thinking you've got to take stuff away? Movement is great. So again, that's going to look different depending on what week of the 4th trimester we're at. but slowly getting us doing a little bit more can help that gut behavior. Our pelvic floor, understanding our pelvic floor is responsible for allowing us to pass a stool. Okay, and if you've got pain, if you've got hemorrhoids, if you've got fissures, this might mean that your pelvic floor is becoming a bit more protective. Or you've had a tear and you've got some stitches and you're worried about that. Your pelvic floor might become a bit more protective and tight and not want to let go. So can we help you with some breathing? And the mind-gut connection is really important. And I think in motherhood in the 4th trimester, trying to find time to go to the toilet can be really hard. You know, you might feel like, oh, I need to go, but my baby's screaming. Well, how do I pick that? I need the toilet, but my baby's screaming. It can feel very overwhelming. And I think supporting individuals to understand that and just how to create some space for themselves, or not to ignore when they need to go, ideally. And I always say there's research and there's reality, and we have to make sure we try and bridge the gap with individuals as we talk with them. So pelvic floor exercises, you know, I'm not going to go into details about how I necessarily teach this exactly, because I think depending on the individual, a personalized assessment is vital. But I think if anyone is struggling with their pelvic floor, that is where pelvic health physios really come into their own. We're here and they're specialists in these muscles. But we have to, again, remember breath connection. I mean, you can all try one now. My biggest thing that I generally use with individuals is thinking about holding wind and bringing it forwards to the pubic bone. So if you're visualizing here, you're thinking about it coming upwards and forwards to your pubic bone, or like you're trying to close around the vaginal opening and relax. So squeeze and relax. Okay, that's how I generally recommend that we start to connect with. If we understand this bit has been really stretched, they need the visualization. There's been a big stretch in the body. Their brain needs to connect back down with this area. Okay, then the different types. So we do some where we hold and we do some where we don't hold. And if I'm honest, in the 4th trimester, I'm not hammering home an extensive rehab program. Okay, I'm talking to them about how do we connect with your body again? How do we encourage you to just start finding space for this in your life? If we add on another thing for them to do, it's not probably going to happen. So what we want to do instead is, I always say, look, try and associate with feeding your baby, and you start doing 5 every time. Start connecting back with your body. If you start doing that as a little plan and a little rehab program with every feed, you'll get more confident and you'll be able to do more as you go on. So it's very important that we make sure that as healthcare professionals, we're not saying do this, do this, do this, where they're already feeling really overwhelmed. It's really important that we think, how can we bring what we ideally would love you to do into your everyday life, and think about how we, I guess, support you to make sure you optimize things, but make it realistic. Overwhelm is not there enough as it is. So I know our time is nearly up, so I'm just going to briefly say, obviously, what I would then support if we're coming out of that early weeks, we're going through the 4th trimester, women are wanting to do a bit more and they're struggling with bladder incontinence. You know, what I'm trying to help them with is, I mean, really nice guidelines state they should be seeing a pelvic health physio. Does that always happen? Sadly not. But I think a good routine of pelvic health rehab, which is graded, which isn't just a leaflet about pelvic floor, that is getting connected with the pelvic floor and then progressively getting it stronger so it meets the demands of what they want to do. You know, I do use devices like recommend Efemia if that's indicated at the right time postpartum. And I'll talk to them about their general bladder habits and behaviors that have maybe come from pregnancy and what we're drinking. I mean, normal to kind of neck a bit more caffeine when you're up 5 times a night, but what impact does that have on our bladder? Is that playing into your symptoms? Understanding that wider picture, which isn't just do some pelvic floor exercises and it might get better. Again, what's going on with your bowels? Are you really constipated? And that's also driving some of your bladder symptoms. We've got to think wider than just pelvic floor exercises. And again, with prolapse, you know, I think this is a huge area of anxiety and concern for very, very good reasons. And how we communicate about prolapse and how we support a woman in the 4th trimester and then onwards with those symptoms is absolutely vital. The language that we use, the narrative that we support them with. Honestly, nothing affects a woman's mental health, in my opinion, more than talking about prolapse incorrectly. And you know, I see it in clinic. It can be really damaging to a woman's ability to feel she can care for her children, the way she feels about herself physically, how she navigates her relationship. So again, early support, early referral, if we're concerned, if they are concerned, is absolutely vital. And support may look, again, like very graded pelvic floor rehab, sorting the bowels out, and maybe a vaginal pessary, if indicated, to support her with activity and with what she has to do in her everyday life. So returning to exercise, the way I view it is 3 stages. Okay, recovery. So that's that first 6 to 8 weeks of the 4th trimester. Rehabilitation, minimum of 6 to 8 weeks afterwards. We know it takes time to rehab muscles. And when you explain that to women, they get it. Okay, they understand when we explain to them their pelvic floor muscles are like other muscles. You're not going to go to the gym and have a body transformation in a week. Your pelvic floor muscles are going to be the same. So we need to put these timescales in place so they understand. Also to support their compliance, you know. They're going to be compliant if they understand why. Okay, so that's really, really important. And then thinking about, okay, well, what are your goals? What do you want to do? You know, you want to run, brilliant. Let's think about how we get from here to running. That's so important that they feel they're working towards their goal. It may not be running, you know, sometimes it's just like, I want to run for the bus with my baby in a pram and not wet myself. Brilliant. Keep that as a goal. It's got to be goal orientated and tailored to that individual, but reintroducing so they feel that they're getting much more like themselves and the life that they need or want to live. But I always decide this Venn diagram, though we have these phases, we've got that recovery, we've got that rehab, and they've got that reintroduction, but in the middle there is reality. And we have to stick there with individuals because, especially in motherhood, you're changing to a whole new way of being. And this may be the first time, the second time, the third time, or more than that. But it's really important, and I think so important as healthcare professionals, that we don't put our expectations and our thought process onto them, but we take where they're at and we mold it around that, because they will then comply and it will be much more relevant to them. Right, there you go. I've just done it in an hour. So I'm very happy to answer some questions if that's helpful. I've got one in the Q&A. If anyone wants to put any more in the Q&A box, then please absolutely do. So question here is, following an instrumental delivery with trauma, so for example, an episiotomy or tear, often they have an epidural as well. Women can also report reduced bladder sensation as well as loss of vaginal sensation. We have a pathway to follow in my organisation, to how to address it. So I think bladder care postpartum and the acute postpartum can be really tricky and isn't always dealt with. So I think essentially, I mean, my feeling of the acute part is making sure that they are passing urine within the 6 hours. They will have a catheter, so the catheter's out and they need to pass urine within 6 hours. You know, reduced sensation can be there for a variety of reasons. Obviously, they're not going to take the catheter out until the epidural has generally worn off and they can mobilize. Sometimes it is kind of like the bladder's been under a lot of pressure. And so I explain that to women, you know, there's been a lot of pressure on your bladder. You may not get quite the same signals. If they have got a lost sensation, what I'm generally doing is time voiding. So, you know, encouraging them to go every few hours to make sure that we're not causing any bladder injury, we're not causing any bladder distension, which can occur, obviously, if they are not passing urine. So that's my general feeling is, again, education of timescales, depending on what we think the mechanism is. Vaginal sensation, I mean, I always say when you've got swelling in an area, this impacts the nerves. When you've got an injury to a muscle, everything is going to feel very, very different. I would say, you know, you'll probably feel different in a couple of weeks. Things will start to change. Then you'll feel very different in another 4, you know, by 6 weeks. But it's also normal to not feel exactly like yourself by that point. What are your thoughts? Yes, great question on breastfeeding with stress incontinence. My party line is we should not be encouraging anyone to stop breastfeeding for pelvic floor symptoms. We should be supporting if we're in theory saying that when you're breastfeeding your estrogen is lower, and could this be one of the reasons that's driving some of your pelvic floor symptoms, my feeling is that we should be holistic in this and be thinking, let's support with some vaginal estrogen, okay, to supplement the estrogen that we are hypothesizing that genitourinary area needs, rather than stopping breastfeeding. Because I've seen it as really damaging for a number of women to say, because basically they feel like they're failing doubly. Their body's not coping, and now they can't necessarily give their child what they want to or feel that they should do because of it. And that's really damaging. When for some women, and I'd say the research doesn't support that we should tell them to stop, okay, for some women it may slightly improve symptoms, but for me not enough to be like, right, stop it and you should stop it. We should be trying to deal with the problem that's occurring because of it rather than stopping it, if that makes sense. Right, yeah, you mentioned giving the right information for postpartum prolapse. Do you think after a V, if you find a mild pop, it's important to say at that point you would tend to use the word laxity? Yes, I love this. So yes, I agree. I think, look, I think within the kind of gynae pelvic health community, we're trying to discuss grading and discussing like when should we be diagnosing definitely a prolapse or not. I think yes, if say 6 to 8 weeks, I notice there are some vaginal wall changes, I will say to the woman, look, I can see there are some changes to your vaginal wall. Sometimes I call it laxity, but sometimes I just describe it. Essentially, your wall is looking a bit stretched at the minute and sitting a bit lower. I sometimes normalize it to in the same way as your belly skin and the same way your breast skin, like everything is a little bit stretched and less supported at the minute. And I then talk them through the anatomical changes of the pelvic floor to say, look, well, it makes sense. If your vagina at the minute is more open, those walls are less supported as well. So we've got two things going on here. So I'm seeing this now and we don't ignore that, but I'm not going to diagnose this as a prolapse because actually it's too early days to call that. So I want you to think about this, and this, prevent the constipation, do this, think about lifting and how we return to exercise. And let's check again in, say, 6 weeks. Ideally, I work in private practice. I'm aware that's a completely different setup to the NHS, but I think women are very receptive to this understanding. But if we start saying prolapse, they're on the Google element. They're thinking they need surgery. So I think we can use, and I probably use different language depending on the individual and maybe what they've come with and how they've articulated things. But that's how I generally do it. Are you recommending intermittent catheterization during labor if epidural? I mean, I feel like depending on the team and how they manage it, I think a lot of women do have a catheter, like an indwelling put in when they are. If not, yes, we should be absolutely making sure that their bladder is emptying. I've heard too many bladder injuries occurring. So I think every trust will manage it differently, basically. Do I use electrical stim for contraction for the right individual? So the research basically says that if they are able to contract their muscles themselves and feel that contraction, then really they don't need stimulation. If you're examining someone and there is no pelvic floor activity or they have really little awareness, then absolutely I would use internal stimulation. So it's like a probe and they have their own little device, and it's something that I'd facilitate for them to then use at home. And there's great results for the right population. Absolutely. How soon after vaginal birth would you advise Efemia if clinically indicated? So I mean, I'd always generally say nothing until 6 to 8 weeks. And I think, again, it depends on the individual and their presentation. You know, for some women, I've just used it when they're returning to running, which would be more like out of the 4th trimester, generally speaking, again, depending on your population. But again, I think it depends, you know, if someone is really, really struggling with stress incontinence, just even factor of standing out of a chair or looking after their baby, you know, as long as all vaginal bleedings occur, they've healed and everything, I think we should be considering anything to support them during that time, because the reality is you still have to do all the things that a mother needs to do, but you're also navigating these symptoms. So I think, yeah, I mean, once everything is healed, if it's clinically indicated, I'm always looking to adjuncts to think, how can we support that? But I think the other thing you need to think about anytime they're putting anything in the vagina, if they're estrogen deficient, the vaginal tissues are thinner, are drier, you know, should we be then suggesting some vaginal estrogen? Again, that's a talk to have with their GP and their medical team, who should also be supporting them with these symptoms at their time. Minimum time scales for returning to running or the gym when symptomatic. I don't think there are any. So I think running wise, I mean, if you look at the kind of return to run guidelines that we have that came out a few years ago and were written by some expert physios, you know, they're suggesting probably the majority of people 12 weeks is the earliest time that any of us should be running postpartum. Now, from a symptomatic point of view, my feeling is we need to do as much as we can to get that woman asymptomatic first and use adjuncts like an Efemia if they're running. Like there's place for that 100%. I think we've always got to keep that individual, their mental health. You know, some women come to me and they're like, look, I actually don't care about going for a run. I just would like to be able to, as say, run for the bus or whatever. Or I'm happy to take it easy. I just quite like to do some Pilates or get my body moving. For some people, running is life, running is mental health support, running is everything. And so, you know, I treat the different populations differently. And I always have a very frank, open conversation about risk versus benefit, what the options that we have. So I think a minimum 12 weeks recovery, and because they need to do rehab. You know, when you say to them it's 6 to 8 weeks of your body just healing, that's not rehab, really. You can start rehab, but it's not full rehab. And if you relate that to a hamstring tear or something else like that, you would not probably go on a 10K run 6 to 8 weeks after that. You would do some straight, stage rehab. So that's the same thing that I would get them thinking about from a pelvic floor perspective, which often takes you beyond 12 weeks anyway, and then do a graded sort of return to run. So though I work in clinic, as I think about ways that we could start introducing some impact to the pelvic floor before we're then like hounding the street and running. So I hope that answers. Obviously, it's very, I think the gym, they can be generally more asymptomatic in the gym by doing some kind of body weight and light weights or things like that. But again, individuals will have different triggers that are causing their symptoms. Is it incontinence that we're working with? Is it prolapse that we're working with? So I think depending on what we're treating, but if I'm honest, I just always go incrementally with every individual based on their symptoms, their goals and their wishes. And some women, we just cannot get fully dry, and they make that choice that they're like, you know what, I'm better, but you know what, I can't give up running. I love my running and I would rather wear a pad. And I think though at times that for us probably medically feels a bit wrong, it's an informed decision that they have to make, and we need to be the ones who are there to give them, you know, the right leggings or the right underwear or the right other support to help them in that process. So that's probably a long answer to it's complex, but there's lots of things that I would think about. And there's one more question here. So when you ask for a prescription of vaginal estrogen, what do you report to the prescriber? I have real issues getting. Yeah, it is really hard. I'm married to an NHS GP. I always say that because I have these discussions with him all the time. It can be really, really hard. And the reason is because we don't actually have clear guidelines on the use of vaginal estrogen in the postpartum population. Now, if you have specialist trained GPs, or gypsies as they're often called, that are a specialist in women's health, they might have done a diploma from the Royal College of Obs and Gynae, or if it's a urogynecologist, they are very supportive in prescribing postpartum. So sometimes what I'd advise is looking at a GP website and seeing if anyone has done a diploma from the Royal Obs and Gynae and speaking to them. What I generally say is, you know, I've done a vaginal examination and I've noticed vaginal atrophy, depending on their symptoms. So say if pain with intercourse and they've maybe got some splitting, or maybe it is related to prolapse and they're much more symptomatic. And I'd say, look, these are the symptoms I'm trying to support with. This is what I found clinically. We are doing X, Y, and Z to support them, but I feel that it could be worth us trialing the use of some vaginal estrogen. And I'd appreciate your expert review. I often then give them my contact details, say I'm more than happy to discuss this with you further. I've sort of asked many GPs who are happy to prescribe and say, what can I send? And they said, to be honest, it's really tricky because we don't have any guidelines or research to be like, look, this proves that this is safe. There's a lot of concern about milk supply, but there isn't circulating. It's not the same. So, you know, it's a vaginal estrogen. It's not the same as a tablet. It's not the same as a patch. But there's fear around it. And obviously, if a woman hears it's going to affect her milk supply and she is breastfeeding, a woman is generally not going to want to do that. So I think it's tricky. I think it's just coming alongside our GPs and trying to discuss, trying to work out who in that area is maybe a specialist, who might then be able to support education of others. But I hear you, it can be really frustrating. And I guess the privilege I have in private practice is sometimes I can get a women's health GP to support that. But a lot of the time I'm navigating the NHS in the same way. I don't always manage it. But I think we just can do our best, and that's all we can do. Amazing. Well, thank you for having me. And I'm glad that was helpful. Great. I'm just looking through any other things. Oh no, well, thank you everyone for listening, and apologies if there was any banging. I've got building work going on. I told them to be quiet, but I'm not sure if they were. Well, they weren't. I could hear them, but I'm sure you could too. So I apologize in advance after that. But yeah, thank you for listening and for your great questions. You know, this is how we all learn. And yeah, have a great afternoon, whatever you're doing. Take care.
Thank you so much, Claire. That was amazing, incredibly informative, very engaging. I love the holistic approach to all aspects of pelvic health. And yeah, amazing, wonderful. Just to remind everyone, this has been recorded. It will be posted to our website. And we do have another presentation in the series next Tuesday at 1 p.m. with Elliot Stackhouse with a deep dive into Efemia, the clinical evidence behind its design and how it works so well. So thank you all so much for joining, and have a great afternoon, and we'll see you again soon.